I think if we can make direct primary care, ketamine-assisted therapy, all these things part of that process and get them available to the most number of people possible at the most affordable rate possible, then that's where the magic happens.
Welcome to Healthcare Liberty Labs with Tiffany Ryder, where we teach you what they don't want you to know about healthcare.
The evidence shows that traditional treatments for addressing mental health are simply not enough. For a lot of people, they're failing. For some people, they're helping, and I'm really happy for those people. But for up to 60% of people with a mental health condition, traditional treatments don't work. They are treatment resistant. It's very rare. I could spew out a lot of statistics about how, 57% of people on SSRIs have moderate to severe side effects, or how, they meaning SSRIs or antidepressants only really work well for 15 to 20% of people that take them. But statistics aside, if you, the listener, people listening to this podcast, or someone you care about has ever experienced a mental health issue or talked to people who've experienced a mental health issue, it becomes, easier to remember, wait a minute, like, I don't actually know anyone who's told me they had depression and they cured themselves, or they had anxiety and it's like completely gone. It's always usually lingering. They might find ways to mask the symptoms, cope with the symptoms, but not say, it's very rare someone says, yeah, my PTSD is completely gone, kicked it in the butt, I'm 100% better, I don't feel it at all anymore. And that to me is a problem. And that's the exciting opportunity with psychedelic-assisted therapy and ketamine-assisted therapy, because many people have reported that they actually did get to the root cause of their trauma and feel better. And I'm sure we'll talk about it in detail, but I'll leave it.
Yeah, for sure. Well, I know, as a clinician who's practiced in the emergency department, what the story you just told has certainly been my experience, right? Like, you never hear someone come in and say, oh yeah, well, I used to take, this SSRI, the Zoloft or whatever. But then my depression was cured and now I don't have this issue anymore. Like this is not the story. It's almost like these Band-Aids. And, if I see that from the emergency room side, it's certainly something that primary care is dealing with day in and day out. Is this so Jeff, what is your background? What is your experience in treating, mental health in the primary care space?
I think one of the biggest problems we have in the country in general is keeping primary care and mental health in these two separate silos. To me, they're have always been and really are one and the same. Everything we do in primary care is really some degree of psychology, whether it's counseling someone on weight loss, finding what their barriers are to take medication, dealing with their mental health. It all kind of falls under the same basket.
Why do you think we are seeing psychedelics being part of the conversation in some areas and maybe not part of the conversation in others?
Yeah, because what we're doing isn't working. I mean, we have a mental health crisis, in this country that, is at the point where, you have an unlimited demand with a very limited supply. The word alternative can be applied to a lot of things, alternative payment model, alternative medicine. But the reality is, like, human psychology and human behavior is something that doesn't fit a checkbox. And our job is to try to do what's right for the person sitting in front of us. Yes, we always try to use the best evidence that we have access to, but you have to check where that evidence is coming from. And then apply it clinically to the person sitting in front of you. And that's where I think, the other person on this call, who I need to shut up and let her talk, is onto something, because this is something that can actually be done extremely affordable for not a lot of dough. It is relatively safe in a majority of patients. if done appropriately, and could actually fix this problem.
Yeah. Which is a powerful statement in itself. And, Sherry, like, before you get into the results of how we fix it, I mean, one of the things that I think is so cool every time I talk to you is every single time I talk to you, I'm like, hey, how's it going? You're like, well, I've been in 6 countries this week and talked to 8,000 people, right? Like, you are, I think one of the greatest values that you bring to this conversation globally is that you are talking to humans who are suffering. What are you seeing? Are we exaggerating the mental health crisis? Are Jeff and I just like seeing patients who are suffering more than other people?
No, absolutely not. So on the mental health crisis, worldwide, mental health is the leading cause of disability. In the US, last year, the Surgeon General put out a warning saying that 76% of employees have at least one mental health symptom. Often, we say that 1 in 5 American adults have a mental health illness, so not just a symptom, but like a diagnosable condition. But that's at any given point. But throughout our lifetime, the probability is 1 in 2. So, over the course of your life, 1 in 2 people, so you have a 50% chance of at some point having a diagnosable mental health condition. This costs employers in the US $3.7 trillion a year, not billion, but trillion.
Is that in productivity or is that in
combination of productivity, retention costs, and then just the healthcare spend? So
Yes.
All of it combined, and roughly like a third of the cost in each of those 3 buckets. And then I shift between, like, I know a lot of the listeners are probably American, but sometimes I have to think like globally, like every 40 seconds, someone takes their own life globally. So I don't think we're exaggerating the crisis at all. I think even though since COVID, especially, people are much more comfortable talking about their mental health. And, not just since COVID, even in the past 25 years, like it's become more normalized to say, I am going to a therapist, or I need therapy, or I've seen a therapist. Like these things have become much more normal. We haven't really fixed the problem. We've made it more normal, which is great to talk about our mental health, not so normal to find solutions. So no, you're not imagining it. And then to your other question, which Jeff nicely answered, I'll just add, so how come, like, is this fringe, or like, or are people taking psychedelics seriously, or like what's happening behind that? And what I'll say is, right now there's over 100 clinical trials involving psychedelics registered with the FDA, like on the clinicaltrials.gov site. So just in the US, there's over 100 active trials. There are over 30,000 published articles on psychedelics in peer-reviewed journals. And what we've seen is, like, in the 50s and 60s, there was a lot of psychedelic research. And then, if it was like a bar graph, then these substances became scheduled. So there was like a few decades where there was almost no research. And then we are now in what's called the psychedelic renaissance in the 2000s, where the research started again. And that's why we have all of these active trials. And what has shifted is people have some of the data from these trials and papers have been released, and they're quite remarkable. Like the phase 3 clinical trials for MDMA-assisted therapy for PTSD show that 65% of people with PTSD, after they did MDMA therapy, no longer meet the criteria for PTSD, which is mind-blowing. Like we were talking at the beginning of this conversation about how nothing is working, everything is a Band-Aid, and here's something where people no longer qualify for PTSD. So that's shifting, like getting this data out has shifted perspectives. But then you have people with very large platforms who have gone and sought out these experiences for their own healing in places where it's legal. So a lot of vets have gone to treatment centers in Mexico and Jamaica. Joe Rogan has done his own healing. Mike Tyson has gone and done his own psychedelic experiences. There have been many people that have fortunately talked openly about their use of psychedelics. Prince Harry, I think, is another one. And so people with big platforms are sharing how these medicines have transformed their mental health. And that's also caused a shift, because when you get a big name, then it gets media attention from Fox and CNN and, you know, like bipartisan support on all sides. And so that's also shifted too, because people are now talking about this and hearing about this from the people they follow.
Let's just take one step back. I mean, when we talk about psychedelic medicine, and I ask this question because this was a legitimate question that I had probably within the last 2 or 3 years, like I didn't even know what that meant. Right. I know I use ketamine in the emergency department on the littles if I need to, repair a wound on their face or something. But, outside of that, episodic ketamine treatment, I really wasn't familiar with what a psychedelic even is, and then which one of those can be used with some sort of expectation that there's a medicinal benefit.
The word psychedelic means, like, psyche means mind. Delic comes from delos, which means like manifesting. So the word literally means mind manifesting. But if you think about, what does mind manifesting mean, right? And so that concept of something that's like manifesting the mind is really bringing our mind in front of us. So there's a lot of stuff happening in our mind, in our brain, that we can't see. There's, things that are happening subconsciously. And so psychedelics, they say, sort of lift the veil and allow us to tap into these other states of consciousness, sort of the unseen. I know this sounds a little woo-woo for people who have not experienced a psychedelic, but it's really tapping into what we can't tap into in our everyday life. And so now, in terms of like, what are these substances? Well, there are many, many, many psychedelics out there, some that we know about, some that we don't know about yet. And they're categorized in different ways. So there are DMT type psychedelics, which is what is found in toad venom. There's a very common one that, going back to Joe Rogan, that he talks about. He's talked about it a lot. And then there are mescaline based psychedelics, which come, on the DMT, also ayahuasca. People hear about ayahuasca a lot. That's a DMT based psychedelic. Then there's mescaline based psychedelics, and mescaline based psychedelics come from like different forms of cactus, like San Pedro or peyote. So these are different words, but all different types of cactus kind of plants. Then there are traditional psychedelics, which people refer to as like psilocybin and LSD, are the traditional psychedelics, because they work on the 5-HT2A receptor in the brain. And then there's MDMA, which most commonly is known as, I guess, ecstasy or Molly in recreational settings. But there's more. There's ibogaine. I'm not going to list all of the psychedelics, but and while they might work on different receptors in the brain, what they have in common, all of them, whether they're traditional or not traditional, or cactus or not cactus, is they all increase neuroplasticity in the brain. And so they allow many more connections to form in our brain. They allow us to break negative cycles or patterns and create new patterns and new behaviors. And in that altered state, they allow us to remove our masks and kind of get in touch with our real self, which then, with the help of a guide or a therapist who's trained to work with someone in that state, you can actually get to the root cause of your trauma, of your anxiety.
I mean, I think that the key thing that Sherry mentions is this isn't, going to a Grateful Dead show and dropping LSD or mushrooms. I mean, people do that for recreation. That's fine. I mean, we're talking about using it in a way that is monitored with a professional guide, sitter, therapist, physician, because, one of the things we talked about, I took a year-long course in psychedelic medicine, and, the term bad trip, always comes up. And I think a lot of that is actually the kind of stuff that actually really does need to be dealt with and processed and worked through with a professional. If these medicines aren't given correctly and in the right set and setting, I think sometimes the trauma from the experience can actually be worse than what the original trauma was. And that's why, we're really trying to do this in a monitored, medically appropriate, correct dose, make sure it's the right patient, the right medicine, all that kind of stuff. So I think Sherry mentioned the default mode network, and the comparison that I like to use, it's almost like your CPU, your computer processor that's just running in the background. But unless you're a specialist, no one really knows how to access it. And it's almost like it allows that area of the brain to kind of come to the forefront. They use the term ego dissolution a lot, where we develop, from our environment, from our history, all these mechanisms to try to protect ourselves. And a lot of times we compartmentalize things, like she said, not intentionally, but really to protect ourselves from things that have happened. Not all bad, sometimes we have good memories that we forget about. And then it's like, whoa, totally forgot about that. Yes, the downstream effect is cost savings and all that stuff. But the best frontline effect is actually making people happier and better and able to cope with the hardships of life. I mean, life has a lot of beautiful things, but there's also a lot of challenges that come up. And I think right now, like, the lack of coping mechanisms we have is just astounding.
This episode brought to you by Crowd Health. Crowd Health helps you find awesome doctors, negotiate your bills, and fund those bills through our peer-to-peer funding platform. For less, welcome to an easier way to pay for healthcare.
I would love to know, because I honestly don't know. I know that that I hear people talk about it, right? They, like media sources, whatever. And it's like, oh, this is dangerous, or this is something we shouldn't be doing. And, my response has always been, well, I give ketamine to 6-year-olds, right? Like, on the regular, right? So like, okay, maybe there's something I'm missing here in the literature, but I haven't found it yet. But what I haven't seen is the other side, right? I haven't treated patients for any of these things, for trauma or mental health disease or symptoms. So I haven't seen the upside of it. What's been your experience, either of you, in seeing patients undergo psychedelic treatment? How are their lives different? And, are there bad outcomes that you've seen, read about in the literature? Let's get into the treatment side of it, I guess. I'm curious.
I'll start. Honestly, the numbers are like unbelievable. So I mentioned with MDMA that 65% of people who did MDMA therapy in the phase 3 clinical trials for their PTSD no longer met the criteria for PTSD after the MDMA therapy. There's a study by University of Exeter that showed with ketamine-assisted therapy, and often people don't associate ketamine for its benefits with substance abuse or alcohol abuse. But with ketamine assisted therapy, 86% of heavy drinkers completed ketamine assisted therapy, and at 1 year follow-up, 86% of them were abstinent. So not just like
Wow.
they cut back, they completely stopped drinking, which is like, just, think about how much that would affect our healthcare system, their lives, their families' lives, road accidents, like so many things.
Yes. Anybody who's seen someone with alcoholism in the hospital with a swollen belly full of, yellow fluid, like, how can we not be exploring options like this if we're getting an 86% success rate?
Exactly. And then with Enthea, I know I'm biased, but I have to like rave on about Enthea's data. We've seen a 67% reduction in anxiety, a 65% reduction in depression, 86% reduction in PTSD, and 80% of people get off of their antidepressants. And even at follow-up, like 3-month follow-up, they were still off of their antidepressants. So actually getting people to a point where they're feeling better. Then there's another study, which I forget, I think it's Matt Johnson's study. I forget the university, but another study that I found really interesting with psilocybin, which showed that 80% of people that completed the psilocybin therapy that were heavy smokers, 80% of them after completing psilocybin therapy were no longer smoking at 1 year follow-up. So again, like super helpful for depression, anxiety, PTSD, but also for alcohol use, also for smoking.
Wow.
And smoking is also puts a huge drain on our healthcare system because of all of the things that happen when you smoke all the time. Yeah. So and just like if you do know someone who can't seem to quit smoking because it's so addictive, imagine doing something that helps you totally stop so effectively. And then right now, I don't know the statistic, but I know that LSD is being looked at, and there's FDA trials for LSD and anxiety. And psilocybin has been given breakthrough status by the FDA for its effects on treatment-resistant depression.
Okay. But the only one that, for example, Dr. Gold could prescribe to a patient in his practice would be ketamine. Is that correct?
That's correct. Yes, that's correct. However, worth mentioning, especially timing wise, Colorado and Oregon have, at the state level, said that psilocybin is okay for treating mental health issues. So Colorado and Oregon have done that. And then as of last week, New Mexico has followed suit. So New Mexico also said as of last week that psilocybin therapy is going to be made available in New Mexico. So it's not FDA approved. A doctor can't prescribe it, but it is available in those states.
So you also, like you mentioned, the 86% resolution for PTSD and reduction in anxiety and all of these successes. What is the actual treatment regimen that is being put into place in these studies? Is it like I go in one time for a ketamine IV infusion, or like what is the mode in which people are getting the drug into their system, and like how long is the process? What does that look like?
Yeah, so for ketamine assisted therapy, it starts with an assessment. So you don't just go in and get ketamine that same day. You would go into a clinic and they would do a medical and a psychological assessment to see if you are a good fit for ketamine assisted therapy. So let's just assume you are a good fit. Most people are, but some common reasons why you might not be is if you're pregnant, perhaps, or breastfeeding, or have really high blood pressure. There's different things. So let's assume you do the assessment, you're a good fit. Then the protocol starts with preparation. So you would meet with your therapist. that's trained in ketamine-assisted therapy. And you would meet, for some people, it's just once. For some people, it might take 3 meetings. But the point of the preparation sessions is they're very intentional, and you should get to a point where you know why you're doing this treatment. You know what your goals are. Your therapist understands your, background and different issues you've had, but you also are trying to reduce the fear and uncertainty so that when ketamine is administered, you're not walking in and being like, oh my God, what's going to happen? I'm so scared. I'm going to go to this altered state. Like, you're not supposed to have that fear. There's always, some nerves, but hopefully when you're done your preparatory sessions, you know what you're getting into, and your therapist knows enough about you to be able to help. And then you go into what's called medicine sessions, where ketamine is administered. It can be administered IV, so through a drip. It can be administered IM, so through an injection, or it can be administered sublingually, so through a lozenge. That's generic ketamine. There's also a branded form of ketamine that Big Pharma created called Spravato. That is like 100 times more expensive, and that's administered in a nasal spray. But for all intents and purposes, we're talking about the protocol with the generic ketamine. So the ketamine is administered, and it's a dissociative. So you will be in an altered state. It's kind of like an out-of-body experience. And most clinics that do ketamine-assisted psychotherapy, not just ketamine IV drips, will give you an eye mask and some headphones. And you're kind of like in a room that looks a little bit like a spa, usually. And there'll be someone in the room, so you're safe. It's in person and it's supervised. But you are given an eye mask and a playlist because the point is to go inward. So going back to the meaning of psychedelic, being mind manifesting, getting rid of all of those masks and layers, and connecting with the authentic you. So you spend some time going inward. Some people will talk, most people won't. You'll be in that altered state for a while, for about 45 minutes is the, majority of it. And then post that experience, you'll do what's called integration, which is when your brain is still in a neuroplastic state, and you'll talk to the therapist and sort of cement all of the epiphanies or lessons or realizations you had. And some clinics will do that integration like right after the ketamine wears off, so that same day. And some will do it sort of within the first 72 hours. So it depends on the clinic. And you'll do, every person is different, but with ketamine, you'll usually do up to 6 sessions. Some people might need a couple more, some people a couple less, but on average, 6 sessions. And that whole protocol, like the preparation, medicine, integration, is the same protocol for other psychedelics. It's just in a clinical setting. It's just with psilocybin and MDMA and LSD, you won't have as many medicine or dosing sessions. You might have 1 to 3.
Okay, interesting. What haven't I asked that I should ask, Jeff? Help me out here.
Yeah, I think that's a pretty thorough description of the way the process works. I mean, I don't think it's, just willy-nilly anybody. I mean, although some of that unfortunately is going on, but I think when you're doing it with a purpose of, healing or exploring your inner thoughts in a safe way, this is the right way to do it. I mean, the handful of patients that I've done sessions with, and I've only done the oral lozenges, which, you have to give a little higher dose because the bioavailability isn't, as full as IV or even IM, and takes about 20 to 30 minutes usually to really kick in. It's to be in the most comfortable setting possible, the safest setting possible, I tell people, if they want to talk or have me write something down, that like, I'm happy to do that. A lot of times, most people, I think Sherry would probably agree, are usually more quiet and like inward and, um, just kind of go do their own thing. But I think the key is the work afterwards, to really, whether you have your own therapist, to talk to them about what you felt, what you experienced. It's a tool. It's not a cure all. It's part of the whole process to hopefully get cured. So, yeah, I think that there's just so much opportunity here, and in a positive way. And the fact that this stuff is illegal to me, but yet you can go drink a 24 pack of Miller Lite tonight and not have any worry about accessing it or getting it is just so ass backwards to me. But so much of the world seems ass backwards to me, so I can't really get into it too much. We could be here all day.
We're so optimistic.
Two questions on safety. My experience with ketamine, whether it's the $1 million nasal spray or IV ketamine, it requires all of this monitoring. There is a nurse there for several hours. There's a lot going on before we administer ketamine. And again, most of the time it's in this pediatric population, which I know is its own special case. But, when you mention things like end of life care, palliative care, it really, I think, begs the question of, are there ways for us to administer things like ketamine in the most comfortable environment, which is the patient's home?
Yeah, I'm going to do it. I mean, I incorporated a side business earlier this year with the hope of marketing to terminally ill or, chronically ill patients that can't necessarily leave their home or are homebound. Not doing IV, would do mostly IM or oral, and then be with the patient, and again, going over risks and benefits, preparation, all that kind of stuff. But really, the drug itself is not expensive. What's expensive is the time, and the expertise that you're going to someone who knows what they're doing. But I think it can be done really affordably and really safely, and in the comfort of someone's home without them having to go to a clinic. I mean, this whole like go to the clinic thing is really, an insurance based way of getting paid. But even so much of what we do in regular medicine can be done effectively through telehealth if there's an established relationship. Now, I'm not saying I would do this stuff, even though I know there are companies out there doing it. I won't mention that I'm not really a big fan of, but I think when you have an experienced sitter or professional who knows what they're doing and knows how to be with someone, why couldn't you do it at home?
Yeah. Interesting. And, do you see potential for, let me just be honest and disclose, my direct primary care physician offers this service right in his office. I haven't used it, but it's there and I respect him. He's a excellent physician. He runs a great business. I mean, do you see this as something that, perhaps we're going to start seeing ketamine treatments just administered in our primary physician's office?
I know it's for Jeff, but this might be where my dear friend Jeff and I disagree on something, maybe.
Oh, I love that.
So I think we're going to disagree because one thing I wanted to say, even to your previous question about safety, was like you asked, can people do this in their home? I think I would trust Jeff doing it in people's homes because I know Jeff and I trust Jeff. But on paper, if I didn't know Jeff, I might be reluctant to say Jeff could do it in people's homes. And again,
Sure.
I know Jeff is great, and this is kind of like where things are not so binary. One of the things that concerns me about the ketamine space is you have a bunch of ketamine clinics that are popping up all over the country that don't have a therapist on site. So they do have a nurse, they do have a doctor. They're administering ketamine via IV usually. And then they just let you sit there and do your inward work. And maybe there's a nurse around to make sure you're okay, but there's no therapist to process everything that you went through emotionally.
Yeah.
And to me, that's not the work. There's data on the benefits of ketamine even without therapy, but we know from all of the other psychedelic trials that this work really needs integration for it to be long lasting. And so I caution against the clinics that are out there that don't have the psychotherapy. In fact, when I speak at conferences, always inevitably somebody comes up to me and says, I tried ketamine and it didn't work. And my first question is like, did you just do ketamine or did you do therapy with it? And they're like, no, just ketamine. I'm like, well, that's probably why it didn't
That's
work.
such a great point. So it's not just not dying of respiratory arrest that we are worried about. It is, are we even administering this in a way that the patient is going to see benefit? Because there's no point in administering a treatment that does have, some tiny risk, even if it's small, without benefit. So that's interesting. So those would be the full thing that you would want is you want to make sure there's a therapist with integration, and you would want to make sure that the medical checks and balances are being done as well.
Yes. And before Jeff jumps in, I think where we can find common ground is that, so remember the protocol of like preparation, dosing, integration. I think it's great if your primary care physician can administer ketamine and is willing to administer it and knows about it and knows about the healing benefits. And all I think it would require is then for that, your primary care physician to partner with an integration therapist. And that can be done virtually. So it doesn't have to be done, like I said, at the same time, in the same clinic, in that same moment. It could be like, yeah, I'm going to administer the ketamine. You trust me to do so. I know it's going to help you. And then here's the number, or here's the platform, or here's the app to do your integration sessions. Make sure you do it within 72 hours. Otherwise, I'm not going to administer ketamine again for you.
I love that. And that's like, what a great story of like how to be creative with access, because access is such an issue, right? And we don't have to, it sounds like we don't have to have some boutique medical spa that has all of these players in the same place at the same time, that there are ways to creatively approach that.
Yeah, I think that, I mean, that's what I've said all along is I think the setting and the set of this are so important, and doing it, with people that, I mean, I even use the simple example of telehealth. Like, I think telehealth is totally different when you're doing it with a clinician on the other side that knows you and you have a relationship with, versus this on-demand like garbage where you don't even know who the person is and the clinician knows nothing about you. This is totally different. And that's where I think, the intro session, the preparation are so important to like make sure that there's some rapport established and trust. And I think that's what's powerful about primary care and mental health in general, is that when you have someone who you feel a trusting relationship, that in itself can be healing. And I think that's the basis of anything mental health primary care is, I always say if I'm going in for a knee replacement, yeah, I hope my surgeon, he or she, is extremely good at what they do. But personally, I don't care if they have a touchy-feely bedside manner. Just fix my knee and get me the hell out of there. I never want to see him again. This is a totally different process, and I think it has to be done right, and there have to be some standards to it, or we can screw it up just like we have many other things that we've done in healthcare. So I don't disagree with Sherry at all on that. I will say, though, that I do think, and I think we're going on 4 or 5 years now of me pushing her on this, like, I do think that I think this landscape is the frontier that needs to be explored, because my hope, not because I'll revert from my usual negative Nancy self, is that this is where the system is going. This is where it has to go. And we're seeing it, as the system crumbles around us. There are these people that are trying to do the right thing and build a better system. And that's the landscape that I see this fitting into, because this is where people are getting real care, in my opinion.
Jeff, I am forever the optimist and you are forever the pessimist. And I think we just completely align here in that, the more that the system falls apart, the more that there is room for the patient. I mean, this sounds hokey also, but for the patient to sort of come in and step up and take responsibility for their health and take some of their power back. And I think that is allowed to happen in these direct primary care offices. And I'm allowed to have the discussion with my doctor who I love and trust and say, look, what are my options? If I start on this SSRI, is this episodic treatment? Or is this being given to me as sort of just a Band-Aid for me to stay on for the rest of my life? Or would I like to try this 6-session ketamine treatment? Or would I like to take a trip to, I don't even know where these things are legal. But I think that these are the conversations that can begin to happen. Is there any patient that would walk in your office? Is there any red flag on a medical history that you would just say, absolutely not, I'm sorry, and no?
I would say with ketamine, and Sherry, please chime in on this, but I would say that it probably is one of the few, if only, psychedelics that there is some addictive potential if used incorrectly. So, I think if there's a major history of polysubstance abuse, possibly, any history of psychotic disorder, me as a primary care physician may not feel comfortable and possibly refer them, to an anesthesiologist that does ketamine or a psychiatrist that does it. But I think for most standard things, it's very safe. But those are really and as she mentioned, pregnancy, that those common sense types of things. That I would say I wouldn't provide that service.
It's interesting because ketamine is extremely effective for substance abuse and alcohol use disorder. But to Jeff's point, so substance use is not a disqualifier. It's, again, effective in treating it. But generally speaking, and each provider is different and their comfort level is different and their experience is different. But usually a provider will say that you can't be in an active use phase. So you need to be clean for maybe 72 hours, maybe 1 week. So you need to get to that point where nothing is in your system when you're starting your ketamine therapy. But I'm not a clinician, so it really does depend on the clinic's comfort. And then, totally agree. Active or untreated psychosis, if someone's in a manic phase or has schizophrenia, then they wouldn't be a good candidate. And then there's some medical conditions like liver disease, hypertension. If you just had a heart attack, not a good idea.
Mm-hmm. Well, it's hard, and I only ask because of what Jeff mentioned, right? There's so much propaganda. There's so much hardcore. And, I'm a little bit of a conspiracy theorist, meaning a lot of bit of a conspiracy theorist, right? So I look at the incentives and I say, well, if I were a pharmaceutical company that was making billions of dollars, on prescribing SSRIs, what story would I tell about, this medication that potentially has the, will have a role at, severely reducing my profits. And so, there are a lot of these stories floating out there, but it's sort of hard to tease out, and this is not a drug that I'm prescribing for these purposes, and it's not something that I'm currently taking, so I haven't done the in-depth research, but it's hard to tease out, well, what is a real risk and what is just BS that supports our victim mentality, current narrative of let's just get this patient in and put them on the conveyor belt and then just keep them there. And so it's interesting to hear from people who have more experience, what you guys think and what actually gives you pause, like pregnancy. Great answer, right? And what are some other things that even, something like a history of a psychotic disorder or addiction can be more nuanced. So thank you for providing that. So Sherry, can we close with how you see employers playing a role in this, because it's such a weird space, like where we're really championing patient autonomy and options, but the employer is sometimes a part of that conversation. So what does that look like?
Yeah, so I think employers have a huge role to play because they can make these treatments accessible. They can normalize them by choosing to cover ketamine-assisted therapy and other innovative mental health treatments, and then other psychedelics as they become FDA approved. By choosing to cover them, they are giving their employees a chance to have access to treatments that might actually work and might actually help them heal. And in turn, the employer will see the benefits in terms of a more productive workforce, less absenteeism, better retention, reduced medical spend, reduced disability, reduced workers' comp. So there are many benefits for the employer, but most importantly, this is the means through people will get mainstream access. And so at least in the US, and because right now it's great that celebrities can talk on podcasts about how they paid thousands of dollars for ketamine assisted therapy or traveled for a psychedelic retreat. But unless it is covered by the payers, which in most cases in the US are employers, then it remains a treatment for the elite that can afford it. And I think going beyond that, if employers in the US do adopt this and do decide to cover this, then it will create a global shift. So like a domino effect, because especially with international companies, if I'm working for an international company like Microsoft in the US and I have access to this benefit, then there's an equity issue. All Microsoft employees should have access. And so it starts triggering things internationally as well.
And Jeff, do you think this is going to be in my primary care office? Well, it's already in mine, but do you think it's going to be in most people's?
Well, I think she also just kind of gave every benefit as to why direct primary care should be part of every employer's plan as well.
I mean, there is that.
Right. And I think there's a very positive chance of this being blended together, in the right way, because again, I go back to my original statement that I think mental health and primary care are one and the same, really, in my opinion. And I think that that's where it should be delivered, with trusted, safe spaces. Personally, I wish employers had nothing to do with health insurance or healthcare at all. I mean, I know that's a pipe dream, and it's been that way since World War II and probably isn't going to change anytime soon, unfortunately. But that's where I do agree with her, that I think most people in the US get their health insurance through their employer. And I think if we can make direct primary care, ketamine assisted therapy, all these things part of that process and get them available to the most number of people possible at the most affordable rate possible, then that's where the magic happens. And I think that's where you will start slowly seeing, as Malcolm Gladwell wrote in Tipping Point, it's usually not the first person to do it. You need the mavens that spread the gospel and get more people to realize that this is not only effective, but it's safe and can also be done really affordably.
Well, thank you guys both for being willing to come in and talk about it. And I'll obviously link to some of the studies that you mentioned, Sherry, and then as well to places to contact you in the show notes. So thanks so much.
This has been the Healthcare Liberty Lab. Thank you to our listeners and our sponsor, Crowd Health, for making this possible. Be sure to subscribe wherever you listen to your podcast, be it Substack, YouTube, Spotify, Apple, or somewhere else. We're glad to have you with us on this mission to rethink healthcare together.